So I'm actually pretty anxious about the bell at the end. I'm also pretty humble. It's really hard to be a hematologist oncologist in the community. There's so much. I'm happy I'm restricted in the disease and in my responsibilities. I'm also pretty humbled with my colleagues' enormous advances. So I'm going to take you very, very quickly through what's interesting in terms of the new pathophysiology of aplastic anemia, frame that, I hope, in an educational way, and then the treatment options. Let's make sure I can advance this. Yeah, okay. I had nothing to declare, work for the government, or at least up until today. Where's Rick? Yeah. So aplastic anemia is an historic disease, goes all the way back to Ehrlich's description. I love this slide. It was fun to put it together. Really famous people have studied it. You know, if you work with progenitors, it's fun to have good progenitors. That's great, except there are a couple of problems when you go back to the history. One is that all these guys are essentially pathologists because patients died and all they had to look at was the bone marrow. Aplastic anemia stood out, especially in the 19th century, because it was empty. Ehrlich contrasted that with what was the deadly anemia of 150 years ago, which was pernicious anemia. We don't even talk about that at sessions like this today. And the other is that there was a focus early on, for perfectly good reasons, on chemicals, benzene. So a lot of the early field was dominated by the pathologists and by chemicals. It's a very hard disease to study for multiple reasons. One is there's nothing to study. We're one of the few medical illnesses in which the organ of interest has actually disappeared. So do the patients. Early on, when we were studying these patients, they would die within a few months. You could never go back and get a second biopsy, and it was, of course, very hard to take care of them. And there was this idea of heterogeneity, many, many different causes. How could you ever get a homogeneous population together to do formal studies? So this is, after 50 years of studying the disease, it seems like a long time even to me. I put together in a review in the Aplastic Anemia a few years ago, which I would refer you to if I confuse you by speaking so quickly, to reframe the way we think about aplastic anemia, recognizing that the pathology has been the unifying feature, that empty bone marrow, but is not the definition, and the definition really should rely on the combination of course, clinical appearance of the patient, the pathology of the empty bone marrow, but now what I think are really quite discrete roots to the pancytopenia and to the empty bone marrow. The one is, of course, the one we do all the time. It's iatrogenic. You have chemotherapy, radiation therapy, wipe out the bone marrow. We don't actually consider that a disease. That's a known toxicity of what we use in our practice. The second large group is of patients who have a constitutional illness in which an empty bone marrow is a component, but not necessarily dominant. Think about Fanconi anemia and so on. And then the disease, aplastic anemia, which is almost always immune-mediated. There are a few important diseases that are inherited or constitutional, perhaps acquired in utero, that as adult hematologists we should be aware of. I'm emphasizing telomere disease. I think that's the most common. It can really fool you. You can see patients in their 40s, 50s, and 60s without a family history, or you don't do an accurate family history to pick up the strong components of pulmonary fibrosis, hepatic cirrhosis, and sometimes even the classic dyskeratosis features. So be aware of that. Relatively easy to exclude by doing a telomere length. We published one of the first machine learning papers in Blood, which I'll refer you to. It's a complicated paper because it involves computational biologists, but essentially with a set of easily available laboratory tests plus telomere length, you can separate out as a homogeneous population patients who have immune aplastic anemia from those who have one of these actually quite heterogeneous, multi-system, usually presenting early on, constitutional diseases. In this aplastic anemia review, I wanted to reframe also aplastic anemia in the context of not only precancerous lesions, because there's this strong relationship between aplastic anemia in its constitutional as well as its immune form and the later development of leukemia, but also as one of the immune-mediated diseases of the bone marrow and the peripheral blood. Some of this is just made up. The bottom, those circles don't represent anything other than citations. I don't know how Dan Longo allowed me to get away with this. I don't really know what the frequency of these various diseases is. And also, I don't know how much of them are B or T cell. But in general, we can think about this matrix of the immune system working either through the humoral or the cellular or both on peripheral blood or marrow progenitors. I won't go through in detail the most powerful evidence for an immune pathophysiology, but it comes from the clinic. And when you treat patients with aplastic anemia early on, when there was no therapy and all these young people died, ATG, ALG in Europe appeared miraculous because patients recovered, not all, 50% of patients recovered bone marrow function within 2 or 3 months. That was obviously nothing that had been seen previously. I'm going to show you a mouse model in a moment of that. We know that cyclosporin patients often become dependent on it. Their blood counts go up and down. There's efficacy of second immunosuppression. And most recently, those who do oncoimmunotherapy have recognized that lymphocytes that we infuse or blockade of the repressors can lead to cytopenias and frank aplastic anemia and related conditions. Now, there's a lovely animal model. Sorry, I skipped ahead. There's a lovely animal model that we've developed, others have used, which really demonstrates the potency of the immune system. You can put a very limited number of lymphocytes from a lymph node that don't contain hematopoietic stem cells. You put those into a mouse, and you essentially create transfusion-associated graft-versus-host disease. Within a week or two, you wipe out the mouse bone marrow. It's infiltrated with T cells. It's a very useful model to look at plausibility of immune mechanisms as well as potential therapies. Thinking back on the early days, how could we imagine that eye drops containing chloramphenicol could wipe out the bone marrow? It seems so silly, but it's really convincing when you do these experiments or you make observations in patients that the immune system is extraordinarily specific and extraordinarily potent in its effects, negative effects on the marrow. Now, there's a revolution going on in hematology that I don't think yet has reached the clinic, but will lead to clinical advances, and those are single-cell techniques. They've given us really a different picture, extraordinarily different picture, as shown on the right, of what hematopoiesis looks like from the hierarchies that we learned when we were going to hematology grade school. It's not that cascade. It is compartments of cells that often are lineage, multi-lineage committed. And the beauty of doing single-cell work, especially single-cell RNA sequencing, is that not only can you identify cells by their state of differentiation, by their cell cycling, but also what are they doing? What genes are on and what genes are off? This is a paper that I think will be in press by the end of the afternoon in Nature Communications, in which we've had an examination of the aplastic anemia bone marrow that is at a level that to me was unimaginable, in which we can actually computationally look at all the cells in a patient pre and post immunotherapy. Now, I'm showing you the graphics, not the supplements. These papers are almost, for those who are in academia, they're almost unreviewable. There's so much data, there's so much graphical information that's actually provided. There's a huge amount of information that can come out of this work. This single-cell approach, my colleague Katie Patel at Oxford owes my age and also is somewhat skeptical of spending all this money on sequencing and having to hire all these systems biologists who come with their black boxes attached to the cart. He said when he did his first single-cell experiment with collaborators, he reminded him of Leeuwenhoek and the microscope. And I can tell you the same. It gives me chills down my spine when I get single-cell data because I'm seeing the bone marrow in a way that I never imagined was possible. So for this gigantic paper, which everybody should go read when you have a lot of time on your hands, we make some observations that are expected but also unexpected. And the main ones are that, as we might anticipate, the CD8 cytotoxic lymphocytes dominate in the bone marrow patients with immune aplastic anemia. but it's a highly dynamic compartment and also a multi-component compartment. There are lots of different types of CD8 cells. They do different things with treatment, and they have different levels of activity. Of course, they're activated, and they're activated in the interferon and tumor necrosis pathways, as were predicted from much more reductionist experiments. And the second major point is that the immune system is complicated. I ran something called the Center for Human Immunology, which was the hardest job I ever had, because immunology is just impossible. So there are B cells involved, there are myeloid repressor cells involved, as well as multiple different types of regulatory cells in this aberrant autoimmune disease. In fact, the paper is titled Autoimmunity at Single Cell Resolution, because we can do in hematology what's really almost impossible to do in any other medical subspecialty. And the third point is that there's recovery of patients, as I'm going to show you with our triple therapy, but they do not recover their stem cells at 6 months. It's a later population that is repopulating the bone marrow. Now, the limitation in aplastic anemia, I'm showing you different ways of looking at this, is the number of stem cells. And we know that from many calculations, that number is markedly reduced. But whether it's reduced to 1%, 0.01%, or 3%, we don't have the tools to measure. And I had assumed that we had reached the limits of immunosuppressive therapy at 60% or so, because patients simply didn't have recuperable stem cells to allow them to recover. They need a transplant. But we published a couple of years ago this very surprising result that growth factors don't work in aplastic anemia. G-CSF and EPO, they don't work in these patients because the patients are producing huge quantities of their own endogenous growth factors. But very surprisingly, the topomimetic L-Trombopag worked as a monotherapy in about 50% of patients in my clinic who had failed everything else. So the bone marrow could be stimulated, and in these patients there was trilineage response, not just the megakaryocytes responding, and robust response of patients coming off transfusion, going on to chelation therapy. Of course, you know, the drug actually was approved for refractory aplastic anemia based just on our NIH studies. Of course, you don't want to wait for a patient to become refractory. L-Trombopag doesn't have overlapping toxicities, and we combined L-Trombopag with anti-thymocyte globulin and cyclosporin, so-called triple therapy. Also led to approval for the first time actually in the US of the FDA, not only of L-Trombopag, but also of ATG, which had never been tested and approved by the FDA. And you can see here the initial study with its excellent long-term survival. When this paper was reviewed, Dan Longo, and I know Rob is in the room, and he talked about haplotransplants and that, you know, those are important and wonderful. But Dan Longo said, so why are we transplanting anybody with aplastic anemia? So we actually now are at a point where we have really wonderful therapies for patients that lead to survivals that were unimaginable just a few years ago, with on the order of 80% recovery in these patients at 6 months, that critical period when they're very cytopenic, almost half of those are complete responses. And we've updated that initial study of about 90 patients. We have over 200 patients now. Bhavisha Patel and my group has put this together in a follow-up paper. And also, the initial study was reproduced in a randomized fashion in Europe in something called the RACE study. So again, you see this very high overall response rate at 6 months. One point that I want to stress is that older patients can tolerate this treatment quite well. They have the same response rate. They don't do as well if they don't respond, but they certainly have excellent survival, as shown in the upper right, in comparison to patients who are younger than the age of 60. Now, these are Bhavisha's long-term data. Again, the time is short. Look at the blood paper for this long-term follow-up. One of the glorious things about NIH is we follow our patients forever, and we don't have cost constraints in terms of doing bone marrow. So this is a long-term study. I think the median follow-up is on the order of 3 to 4 years. Patients have very good survival. They often do require more treatment and relapse. I'll show you that in a moment. But the big problem in aplastic anemia remains evolution, which is what I'll talk about shortly. Relapse occurs at 2 distinct times. The most dangerous point is when patients come off L-Trombopag and reduce their cyclosporin dose at 6 months. That's, I think, an opportunity for more immunotherapy. And then once we stop all therapy per our protocol at 2 years, there's another bump. This is when patients need to be monitored carefully in terms of doing blood counts and putting them back on cyclosporin if needed. Now, evolution is the problem. It's also an extraordinarily interesting biological problem that is amenable to laboratory studies. So we have 2 types of clonal evolution. Actually, we probably have 3 types, as I'm going to mention. So there's high-risk clonal evolution, and that is almost always involving chromosome 7, either complete or partial loss of chromosome 7, less frequently complex cytogenetics. That's high risk, terrible prognosis, even with transplant, although it's improving. But patients develop other clonal problems, which are chromosomal in nature at this early stage, but do not appear to impact on their survival, and it probably represents selection of cells that are able to resist immune attack. L-trombopag, without question, can increase clonal evolution, including high-risk clonal evolution, in patients who are refractory. So in the initial study of monotherapy, there was definitely an increase in cytogenetic abnormalities that were not worrisome. They were dangerous. Patients had to go to transplant. But we do not have evidence ourselves, nor do the Europeans have evidence that in patients whose bone marrows are relatively pristine, usually early in the course, that L-trombopag has any impact on high-risk clonal evolution. It does not put patients at risk as far as we know. There may be a slight increase in evolution overall, the more benign type. And we reported it some years ago that, as with everyone else, we do genomics, and we and others have similar data, and there's a cassette of mutations that occur and lead to clonal hematopoiesis in probably over 50% of patients with aplastic anemia, and if you include PNH, in probably the great majority. It's a very limited number of genes that are mutated, and we don't understand what the mutations, what fitness they confer, but they clearly have prognostic value. So the mutations are PIG-A for PNH, as you heard from Rob. This is a well-known association, PNH and aplastic anemia. But the others are B-core, which turns out to have a positive, good effect. Patients with B-core mutations, in contrast to malignancies, do great, and the somatic clones are usually transient. But DNMT3A and ASXL1 are the other 2. And they, now we know, do have significant prognostic impact and lead to the 3rd type of evolution. So I told you have low-risk cytogenetic evolution, high-risk cytogenetic evolution, which is almost always chromosome 7, and those occur early, usually within the 1st year. But we've now recognized, and we'll publish, I hope, shortly, that there's a 3rd somatic mutation-driven type of aplastic anemia, which is almost solely due to ASXL1 mutations. Oh dear, I'll finish as quickly as I can. Okay. So let me complete with where we are going with aplastic anemia. We have an early intervention study, which I think is going to be the route to new treatment, which treats patients. You guys start the treatment at home once the diagnosis is made with low-risk oral drugs. We have very high response rate comparable to what we see with our triple therapy, and apparently a very low rate of clonal evolution. So treating early, suppressing the immune system, stimulating the bone marrow. I have algorithms which I published. I won't go through them, but I think the real questions, and this will be my last slide, the real questions remain as to when we send patients to transplant. We can discuss that afterwards. At what ages do we use haploidentical transplant and upfront therapy? Whether we can monitor patients and predict early and late who is going to go on to a poor course, and the role of genomics in the clinic, especially monitoring ASXL1 clonal trajectories. And I'll finish at this point. Thank you.